Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. Thank you for attending session 2 of our Learning Collaborative Empowerment and Self-Management of Diabetes, the Pharmacist and Diabetes Care. Today's presentation will be on nutrition, dietary choices, and lifestyle changes. Next slide. This is a live webinar. At this moment, our lines are muted. If you have any questions, please save your questions. We are going to have a Q&A at the end of the presentation. For that, you can either use your chat box, type your question, or you can also use the raise hand icon and your line will be unmuted. Next slide. We are the National Center for Health and Public Housing, and we are funded by HRSA to provide training and technical assistance to health centers with a special emphasis to health centers located in or immediately accessible to public housing. The information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsement be inferred by HRSA, HHS, or the US government. Next slide. There are around 2 million people living in public housing. 59% of the population living in public housing are female. Around 83% of them are below the poverty line, and 38% of those living in public housing have a disability. Next slide. This is a very important topic for those living in public housing. 9% of those public housing primary care grantees report to have 9% of the total population being served by public housing primary care grantees have diabetes, and the 32% or over 32% of those with diabetes have uncontrolled diabetes. Next slide. In a recent publication, HUD and the Centers for Disease Control and Prevention, CDC, gave us some information about the chronic medical conditions affecting public housing residents and those living in HUD-assisted facilities. And as you can see here, those living in public housing are more likely to be obese or overweight, have a disability, have diabetes, COPD, and asthma when you compare them to the general population. Next slide. So it's my pleasure to introduce today's panelist. We are going to hear again from Teresita Lawson. Teresita is a bilingual, bicultural registered pharmacist licensed in New Jersey. Her role as clinical pharmacist for Suffolk Health Center included implementation of and continued quality improvement initiatives for the Clinical Pharmacy Services Program at Suffolk Health Center. She precepted 6-year Pharm students APP rotation for Long Island University, Rutgers University, and Farley Dickinson University, and her efforts helped to contract Suffolk Health Center as a faculty site for Farley Dickinson University College of Pharmacy. In July 2016, she was appointed Clinical Assistant Professor of Pharmacy Practice. She has since retired from academia and is now actively consulting in the pharmaceutical industry and volunteers her time in helping to educate patients with diabetes live productive and full lives by overcoming barriers to care. Good afternoon, Terry.
Hello, everybody. Thank you, Dr. Leon, and welcome to this session on obesity management. Next slide. We're going to be discussing the prevalence of obesity in the United States, as well as the prevalence of food insecurity and its impact on our special and vulnerable populations. We're going to be able to apply patient assessment techniques in the management of obesity and discuss some recommendations regarding pharmacotherapy in the management of obesity. And we're going to describe some recent guidelines regarding pharmacologic and non-pharmacologic management of obesity, as well as being able to apply a patient-centered approach when selecting that pharmacotherapeutic approach. Next slide. So 42.4% of all men and women in the adult range are considered to be obese. One of several reasons for the rise in obesity are there's not so much access in the areas of vulnerability to healthy food choices, as well as overall our population has become very, very sedentary, although that is changing, but we're still in sedentary mode. And a lot of environmental factors, as I mentioned in the objectives, there's food insecurity, and there's also lack of access to exercise programs that are affordable to people. Next slide. So 9.2% of adults have severe obesity, and it is higher in the female population. There has been a dramatic increase in the prevalence of obesity in the last 20 years. It's jumped from 30.5% to 42.4%, and severe obesity has jumped from 4.7 to 9.2. It affects more groups more than others. So for example, the prevalence of obesity is highest in non-Hispanic Black adults at 49.6. Hispanics follow that, and non-Hispanic whites follow that, and there's less of a percentage in our non-Hispanic Asian population. It was highest in the adult range of ages between 40 and 59. And there are some social economic ties in general. More education had a lower obesity rate, but there's not so much significance in the social economic ties to obesity. Conditions that are related to obesity is heart disease, stroke, type 2 diabetes, as you know, and certain forms of cancer. So it is a leading cause of preventable premature death. And the estimated annual medical cost for obesity in the United States was $147 billion in 2008. And people that have obesity, patients that have obesity, cost approximately $1,400 more than people that have no obesity. Next slide. So the first thing that we ought to do is assess our patients, right? So first thing that you ought to do is document the patient's BMI. And there are several ways that I've illustrated here on how to do that. I always preferred using the chart with my patients. It just seemed to be easier to explain what is the BMI and what it relates to. Next slide, please. So let's talk a little bit about food insecurity. It is something that we should really assess in all of our patients. An estimated 1 in 9 Americans are food insecure. And we're looking at about 37 million Americans, including 11 million children, are insecure with respect to food. And what does that mean? So according to the United States Department of Agriculture, it's defined as a lack of consistent access to enough food for an active, healthy life. I've included the website here for Hunger and Health Feeding America. It has a ton of resources that you could tap into. And we should also look into cultural circumstances that may affect the level of food insecurity as well, and also look into those dietary patterns. Next slide. So many food insecure individuals have characteristics that put them at a higher risk for severe illness associated with COVID-19, as many of you have probably heard. People that are more at risk are those in the leisure and hospitality industry. Those are the industries that have been hurt the hardest during this COVID pandemic. Unemployment and poverty levels increase because of food insecurity and because of COVID-19. Individuals who experience food insecurity are more likely to have poorer health, and an estimated 5.5 million seniors are very vulnerable to being food insecure. Seniors typically have issues with mobility and transportation, with social distancing measures in place that it makes it a lot harder for them. I was very happy to see that supermarkets were opening up early in the morning just for them, and that was very nice. And hoarding is not an option for many of our patients that are vulnerable. They barely have the money to afford decent food, let alone hoard. So our patients' populations that are most impacted by food insecurity are those with low income, low health literacy, low English proficiency, our migrant workers, and as I mentioned before, our seniors. Next slide. This is a picture of one of the resources in Feeding America. You can easily put in a zip code and find food banks in your area for your patients. So it's important to tap into these resources for patients who need it. And I've included the website here as well. Next slide. So they have different national program models available through Feeding America. Of course, we mentioned the food bank, but there's also others like the backpack program, the kids cafe, school pantry, senior grocery program, which is really nice. And of course, we all know about SNAP, and you can find all these resources at their website. Next slide. So besides finding a food bank for a food insecure patient, what other community center options can you look for to help close the gap of food insecurity? I'll give you a few moments to respond. So it's definitely all of the above. I want to stress community partnerships because we have a lot of supermarkets now that have a dietitian on hand for our patients. They're free, so you don't have to worry about the financial impact. There's also YMCAs and girls and boys clubs that you could tap into. So there are a lot of community partners, especially community health workers that can also help tie you into your community and the resources they provide. Next slide. So once you've calculated the BMI, you are able to classify your patient appropriately, whether they're overweight or obese. Here are your treatment options, and I've circled pharmacotherapy because I want to stress that it is not indicated below a BMI of 27. So that's why I circled that. And metabolic surgery is only indicated above or equal to a BMI of 30. Everyone should be attending a program that involves a diet, a physical activity, and also behavioral therapy. Next slide. So we ought to educate our patients on risks associated with being overweight or obese. We should be advising our patients on what that means. What does a higher BMI pose a risk to? These are issues that really go towards motivating your patient, especially when we're educating them on the risks associated with being overweight. Of course, if your patient is suffering an abnormal amount of weight gain or weight loss, that needs closer evaluation. Like, for example, with heart failure, they could be retaining a lot of fluid. So it may not be an obesity issue that needs to be more looked into. And also, if you notice a deterioration in the medical status of your patient, that also needs a closer look at. For patients with a high level of weight-related distress, those that really are embarrassed, are very self-conscious about their weight, we really do need to have an empathetic approach to those patients and allow them to steer us in the right direction. In my practice, we had some patients that refused to get weighed. No matter how much privacy we had. But we did find a loophole in their behavior, and they were willing to maintain a weight and diet journal, which is easily assessed when you meet with your patient. Next slide. Of course, we have to formulate some SMART goals for our patients, and those interventions should include some dietary changes, some level of physical activity, 150 minutes a week, for example, behavioral therapy if the patient needs to be assessed by a behavioral therapy specialist. It would involve pharmacologic therapy and possibly even metabolic surgery, but this is for select patients, and they are adjuncts to diet, physical activity, and behavioral therapy. So I put the ruler method here because I always found it to be a very useful tool in assessing a patient's readiness for change and to engage in those changes for weight loss. And it's also something that is interactive with the patient. It could measure their individual motivation towards achieving their weight loss goals. Next slide. Diet, physical activity, and behavioral therapy, as mentioned before, is designed to achieve and maintain greater than or equal to 5% weight loss. And that's what's recommended for our type 2 diabetes patients who are overweight or obese and are ready to achieve that weight loss. If they are able to lose more weight, there's more benefits in the control of their diabetes. All interventions should be of high intensity, and that means greater than or equal to 16 sessions for 6 months, and achieve a 500 to 750 kilocalorie a day energy deficit in that diet. For patients who achieve short-term weight loss goals, long-term weight maintenance programs are also recommended where available. So such programs should at minimum provide a monthly contact, which as pharmacists, I don't think that's very difficult to do. We see our patients on a monthly basis at the very least, as well as encourage ongoing monitoring of body weight, so weekly or more frequently, and that could be done by the patient themselves with a diary, and other self-monitoring strategies like a food journal, for example. and including high levels of physical activity. That could be increased gradually up to 200 to 300 minutes per week. Next slide. Significant weight loss can be attained with lifestyle programs that achieve 500 to 750 kilocalorie energy deficit, like I mentioned before. But for women, that's approximately 1,200 to 1,500 calories per day. And for men, 1,500 to 1,800 calories per day. And it's important to point out that losing 3 to 5% is the minimum necessary to realize clinical benefits of their efforts. They are progressive. These weight loss is, the more intensive it is, the better benefits they gain from it. So it's important to keep our patients motivated, and if more intensive goals are feasible, definitely put them in place if it's also safe for the patient. Next slide. So help our patients beware of those programs that are really not helpful and can harm them. So many programs out there say, take this pill, do this or do that, and no exercise needed. So really, that's not the case, and they're just wasting their money on those. And we have contact with our patients. We can tell them, look, you need a program that includes lifestyle counseling. It includes some stress management techniques for you to learn, like meditation or mindfulness, yoga, ongoing support. It could be online, they could be in-person groups after, well, if we keep social distancing in place, I don't see why we can't have in-person groups, but for now, keep them online. And then it should also include sustainable weight loss goals. Is it realistic? So remember those SMART goals. They should be attainable. And should also have a plan regarding what's going to happen in the future. How are you going to maintain the weight loss if need be? 1 to 2 pounds per week is really what we're going for here. Next slide. For those patients that achieve a weight loss of greater than 5% in the short term, the use of very low calorie diets, like less than 800 calories per day, should be overseen by medical care settings. So those patients should be referred out to more intensive treatment with medical practitioners that are trained in that discipline. Metabolic surgery, I'm sure you've all heard this about it. There's been multiple random controlled trials that show very promising results demonstrating superior glycemic control and reduction of cardiovascular risk factors in patients with type 2 diabetes and obesity compared with other lifestyle and medical interventions. People that are in this category have a BMI of greater than or equal to 40 or 35 to 39. The Asian population is always lower. And you'll see improvement in comorbidities with metabolic surgery as well. The important thing to remember with metabolic surgery is that screening is definitely required. In those that have an issue with alcohol, tobacco, or substance abuse, they have significant depression, or they show signs of suicidal ideation and other mental health conditions. These conditions should be fully addressed before and after metabolic surgery. Next slide. So an adult patient who weighs 260 pounds, their BMI is 33, asks you how much weight at a minimum he should lose in order to gain clinical benefit. What do you think? So 8 to 13 pounds would be at a minimum what the goal should be in the beginning for this patient, but definitely he will see clinical benefit if just losing 8 pounds. So it shouldn't be, it's not an overwhelming number for people, and you could start there and increase the intensity as you move along with the patient. Next slide. So some useful tips, like I said before, it's important to measure that motivation, but give them reasons, what's in it for them. So it can delay the progression from pre-diabetes to type 2. It can reduce your blood glucose, your A1C, and your triglyceride levels. There's greater benefits with even greater weight loss. And in the Look Ahead trial and other large cardiovascular outcome studies, they've documented benefits of weight loss in patients with type 2, including other wonderful benefits like improvements in mobility, physical and sexual function, and health-related quality of life. Remember that the most affected age group is in the middle age section of adulthood. So these are areas that are very important to people in my age group. In patients with type 2 diabetes who also have overweight or obesity, modest and sustained weight loss has been shown to improve glycemic control and reduce the need for glucose-lowering medications. Greater weight loss produces even greater benefits, including reductions in blood pressure, improvements in LDL and HDL cholesterol, and reductions, as I mentioned, in the need for further medications. Next slide. So when choosing your pharmacotherapy, you should consider medication's effect on weight. Whenever possible, we ought to minimize the medications for comorbid conditions that are associated with weight gain. And remember that weight loss medications are effective as adjuncts, and they should be monitored for safety and intolerabilities at least every 3 months. And regardless of what pharmacotherapy you select along with your patient for weight loss, all patients with diabetes on anti-diabetic agents should be closely monitored for hypoglycemia while on weight management programs, and especially those that include pharmacotherapy. And dietary restrictions can lower the requirements for their diabetic agents, so they will need adjusting as you move along and progress in weight loss. Next slide. So some agents that have been noted to help with weight loss is metformin, although in its package insert and everywhere you look, it's said to be neutral as far as weight, but there is a potential for modest loss with metformin. Alpha glucosidase inhibitors like acarbose are also associated. GLP-1s we all know about. SGLT2s have also been found to have great benefit to cardiovascular health and weight loss, and amylin mimetics like Simlin. And as we all know, agents associated with weight gain are insulin, sulfonylureas, although glimepiride is less likely than your other sulfonylureas like glyburide and glipizide, and TZDs like pioglitazone, Actos are associated with weight gain. Next slide. Antipsychotics, antidepressants, glucocorticoids, injectable progestins, anticonvulsants, and antihistamines have all been linked to weight gain. On this slide, I've included some alternatives in the literature. For example, ciprasidone has been found to cause significant less weight gain than other atypical antipsychotics. Bupropion, which is in the pharmacotherapy arena for weight loss, and I'll get into that in a little while, is also considered an alternative agent. NSAIDs instead of corticosteroids when appropriate and safe. Intrauterine devices and barrier methods are also options. And topiramate and zosinamide may lead to weight loss. And as far as antihistamines, loratadine has shown less weight gain than other antihistamines. Next slide. So the FDA has approved medications for both short-term and long-term use and weight management as adjuncts. I can't, emphasize that more. They have improved glycemic control in type 2 and delay the progression to type 2, as mentioned earlier. And the idea behind it is to help our patients adhere more consistently to low-calorie diets and reinforce their lifestyle changes. They're all contraindicated in pregnancy. All women of childbearing age should receive counseling regarding the use of reliable methods of contraception. And efficacy and safety should be assessed, as I mentioned before, at least every 3 months. And discontinuation of the medication is recommended if the response is insufficient or less than 5% after 3 months, or if there are significant safety or tolerability issues during that time. An alternative medication can be looked into, or other treatment options can be considered. Next slide. Leukosarin has been taken off the market. Back in February of 2020, the U.S. Food and Drug Administration reported a link between the risk of cancer. So right now, they really are asking providers to stop prescribing, and they're asking patients to stop taking Leukosarin and dispose of it appropriately in their garbage or in a take-back program if available. Next slide. So the first one I want to cover is phentermine. It's an amphetamine-related anorexic agent. It acts centrally in the central nervous system. It's only indicated for short-term use, less than or equal to 12 weeks. It is contraindicated in pregnancy, as I mentioned, but I wanted to point out that it's also contraindicated in a patient with history of cardiovascular disease and uncontrolled hypertension. Many of our patients will have hypertension, but if it's controlled, it's safe to give it a shot. If it's agreeable to all parties involved in making the decision on the medication. Concomitant use of MAOIs, co-administration of other CNS stimulants. The elderly are at a high risk for MIs, hypertension, angina, or becoming dependent on phentermine. This is a controlled substance, so keep an eye on our elderly folks on this medication. Drug interactions, the one I want to point out is make sure that you monitor your diabetic patients on anti-diabetic agents for hypoglycemia. And if you have someone that has high blood pressure, that needs to be monitored on a regular basis. Every single time you see the patient, we should be monitoring that blood pressure. And use with patients with seizure disorders, just use very, very high caution there. And we should advise our patients to take it in the morning and not at late evening. It is a stimulant. It will keep them from sleeping. Next slide. Orlistat, it's available over the counter as well as by prescription. It is indicated for the long term, and it's also indicated for weight maintenance. It's taken in conjunction with meals up to 3 times a day. It's indicated with a nutritionally balanced, reduced calorie diet that contains approximately 30% of calories from fat, and that should be evenly distributed through the 3 meals of the day. It is associated with an increase in gastrointestinal events, especially with diets that are greater than 30% in total fat. We should be advising our patients for them to take a multivitamin, being that fat-soluble vitamins are affected Their absorption is affected by orlistat. And by far the most common side effect associated with orlistat is GI associated. That's really the limiting factor, although patients in the studies reported that that does subside. Substantial weight loss can lead to gallstones. Post-marketing reports have reported some liver injury, so we need to keep that in mind. Also contraindicated in pregnancy. Next slide. So what drugs do we need to keep an eye on? Thyroid hormone should be separated by 4 hours. Many of our patients are hypothyroid, so you'll come across this a lot. Cyclosporin should be separated by 3 hours. Our anticoags, they need to be monitored more closely if initiating orlistat. Vitamin K, remember, is fat soluble, and the absorption of that vitamin will be affected. We need to keep an eye on anti-epileptic drugs. On amiodarone, there was a pharmacokinetic study associated with low absorption. And antiretroviral drugs. Our HIV patients need close vigilance on their viral loads. Next slide. Phentermine topiramate, also anorexic, and it does affect, it's centrally active. Topiramate's effect is thought to be on appetite suppression and satiety. If the discontinuation is recommended, it should be a gradual discontinuation, so a tapering down. It can be escalated to higher doses if your patient doesn't respond to the lower dose. And I've included here the escalation recommendation from the package insert. And also, do not exceed the 7.5/46 dose for patients with moderate or severe renal impairment or patients with moderate hepatic impairment. Next slide. Contraindications, as I mentioned before, they're all in pregnancy. They should not be taken. Glaucoma, hyperthyroidism, and MAOIs. Caution should be taken with patients that have existing cardiac or cerebrovascular disease. Just as others, watch for hypoglycemia. And there has been some reports on increase in suicidal thoughts, so manage your patients appropriately, assess them for depression and for any mood disturbances that you may come across. And there was a post-marketing case report on acute angle closure glaucoma. Next slide. Oral contraceptives are not altered by phentermine topiramate. There might be some spotting. So if this happens, it's associated with the medication. I always like to suggest to them that if the spotting does not go away or worsen, that they should contact their physician if the condition does not resolve or worsen. CNS depressants, including alcohol, they may potentiate the CNS effects of phentermine topiramate. And watch for non-potassium sparing diuretics. It may potentiate hypokalemia. Next slide. Naltrexone bupropion. The combination may regulate the activity in the dopamine reward system of the brain, and it helps with food cravings and overeating behaviors. Dosing escalation is recommended, and it's done throughout a 4-week interval, and I've put it here for the maximum of 2 tablets in the morning and 2 tablets in the evening. It does have a black box warning for suicidal thoughts and behaviors. Uncontrolled hypertension is also contraindicated in this case. Any history of seizures, bulimia or anorexia. Opioids. If your patient is on opioids, it can cause acute opiate withdrawal. So those patients should not be put on this medication. MAOIs as usual, hypersensitivity and pregnancy. Next slide. Discontinue the therapy and do not start again if a seizure occurs. I mentioned suicidal ideation before, so we ought to be assessing and screening our patients for depression and any changes we see in their mood or behavior. Patients may be more sensitive to opioids after therapy, even at lower doses, so that's something to look out for. We should be screening for substance abuse. Opioid-dependent patients, including those being treated for alcohol dependence, should be opioid-free. So that is something to definitely take into consideration in that patient population. Next slide. Blood pressure and pulse should be measured prior to starting therapy and should be monitored at regular intervals. Discontinue therapy if you see signs of acute hepatitis. I mentioned this before, if you have a patient with hepatic impairment, use caution. And it may worsen bipolar episodes, so that's something else to look out for in your patients. And of course, measure the blood glucose levels prior to and during therapy. Patients who develop hypoglycemia will need adjustment in their anti-diabetic drug regimen. Next slide. Liraglutide. It's marketed under the name Saxenda for weight management and weight loss. It is a higher dose than Victoza, so the two are not interchangeable. There are some drug interactions with insulin and other hypoglycemic agents. They need to be adjusted if you start noticing hypoglycemia. It is contraindicated in people that have a family history of MTC or men too, even though there has not been a determination made on the actual human risk, but it has been found in rodents. Acute pancreatitis, including fatal and non-fatal hemorrhagic or necrotizing pancreatitis, has been observed. Studied in a limited number of patients with a history of pancreatitis. It's unknown if patients with a history of pancreatitis are at a higher risk for development of pancreatitis, but it is certainly something that as pharmacists we do need to consider in our patients. Next slide. So the resting heart rate can increase. We need to keep an eye on that, and the blood pressure. Suicidal ideation, just mentioned that it can worsen depression, so we do need to consistently monitor our patients for that. It does delay gastric emptying, so it can cause issues with other oral medications, warfarin, and other anticoags. You know, just be careful in those patients and monitor those medications closely. Most common side effects are associated with GI, diarrhea, constipation, and also injection site reactions. And it's also important to make sure that we teach our patients appropriately on injection techniques. Angioedema has been reported with liraglutide, so be careful there. And use caution in the renally impaired. Next slide. What advice is not recommended in a patient taking orlistat for weight maintenance? So it is recommended to skip a dose if you're eating a meal that contains no fat. So if the patient is eating a meal that has no fat in it whatsoever, they don't need to take their orlistat. Next slide. There have been studies with pharmacists with respect to weight management programs. All of them have shown benefits in the involvement of a pharmacist, but I'm going to review the two with the highest number of participants. Next slide. So, as I mentioned, there have been models in community pharmacists alone or as part of a collaborative agreement between pharmacists, physicians, and other healthcare providers, and they've all shown positive results. And Bodomino was conducted in conjunction with community pharmacy screening for type 2 diabetes. Pharmacists delivered weight loss counseling immediately after the diabetes screening, and they were divided in 3 groups: standard counseling, intensive counseling, and high-risk counseling. All of these groups lost a significant amount of weight, and it only showed that even with limited involvement by a pharmacist, can make a significant impact on weight loss, even if it's just a short and sweet interaction between you and your patient. Next slide. And the Morrison study involved a program called the Counterweight Program. That was developed in community pharmacies in Fife, Scotland in 2009 in areas where the counterweight program was not available. So that may tune you into areas of healthcare provider shortages in the United States is where these programs can be instituted. The dietitians delivered the training for the pharmacists. It did involve an initial visit and 9, 10 to 30-minute follow-ups within a 12-month interval. The pharmacies extended their business hours in order to accommodate the program and their patients. They had follow-up visits where the pharmacist provided counseling on nutrition and behavioral changes and reestablished goals if need be, and they checked the patient's weights. And the attendance at the pharmacy-based service was comparable to general practice-based services and had similar effectiveness to other primary care-based weight management programs and at succeeding at their outcomes. Next slide. So some limitations and barriers were reported. Knowledge and training, some pharmacists felt that they didn't receive enough training. Based on what I have read and researched, CPE programs are filling in this gap for pharmacists. And as a caveat, newer graduates are coming out with knowledge that includes population health. It includes not only to interpret and analyze, but also to perform these health screenings and physical assessments. So as we move forward in our profession, more and more of us will be more comfortable with providing these services to our patients. In a Texas study, pharmacists' comfort level or lack thereof correlated with how frequently they counseled. So the more you counsel, the more comfortable you'll become, the more confident you'll become with your patients. Everyone always says the current practice models, we don't have the time, the workflow, or the resources. Well, that needs to change. The models need to change. There are several programs out there. There was one that I came across. It's called Tech Check Tech, where we elevate the technicians to more responsibility, more education, more certification and licensure. and where workflows really improve through that model. There are legal considerations and state scopes of practice, but most states allow collaborative practice agreements, and many have found those to be reimbursable and sustainable programs. The Social Security Act, lack of provider status, we need to continue the advocacy in this field, but COVID-19 has opened more opportunities if there's any light to be put on COVID-19 as far as the pharmacy profession is concerned. It has expanded our role even further. And our facility designs need to be more patient-friendly. More privacy is involved and more needed with people that are wanting to lose weight. Next slide. So we are, again, one of the most trusted professions. I put the Gallup poll link here for you to check out. We are receiving more extensive training in pharmacotherapy, and in most curriculums, we are including physical assessment training. We are accessible, very accessible healthcare providers to our patients. And pharmacists already see their patients at least once a month. A lot of the interactions don't need to take a half an hour. They could be as little as 5 minutes, and just to check on your patients to see how they're maintaining their goals. Next slide. We can use point of care devices. We're checking for A1Cs now. We're checking for lipids. We are assessing blood pressure. So these are all necessary ingredients to a successful program. If we're going to get into obesity management, we'll need scales, height measures, measuring tape, body composition analyzer, pedometers, of course, blood pressure and heart rate monitors and calorie counters, and of course the A1C for people living with diabetes and obesity. And pharmacists, we can provide information and recommendations on both over-the-counter products as well as prescription medications. So we are the ones that can catch the medication problem before it ever happens. Next slide. And according to CMS, we need programs that offer an essential health benefit, as is indicated in the Affordable Care Act. And in 2014, CMS informed the American Academy of Family Practitioners that a physician may bill the Medicare program for pharmacist-provided services as incident to services once all legal requirements are met. And that refers to the state scope of practice, but as I said, most states do allow for collaborative agreements. And I included the codes here for you, as well as the link to the article. Next slide. In the absence of provider status, which of the following are options for reimbursement of services? Definitely all of the above. Collaborative practice agreements are becoming more and more utilized. I also want to point out that fee for service, if Nutrisystem can charge a fee, by golly, us pharmacists can charge a fee. And there are programs out there. I urge you to look them up. It doesn't have to be a large fee, but we can charge for our services. Next slide. What I would advise is that we design the program as per CMS guidelines moving forward. So Medicare does cover intensive behavioral therapy for obese patients, and that's defined as a BMI of greater than 30. The covered therapy should screen for obesity. We should do a level of nutritional assessment and counseling. I used to use the plate method in my practice, very visual and very easy for patients to follow. And according to CMS, therapy for obesity consists of screening for obesity in adults using the measurement of BMI. Even though there are better ways to help with measuring the composition of a body, it's still BMI. And dietary assessment and intensive behavioral counseling and behavioral therapy to promote the sustenance of the weight loss throughout the program, and of course diet and exercise. Next slide. And we're all familiar with the 5 A's: assess, advise, agree, assist, and arrange. And CMS guideline utilizes the 5 A's. So we need to ask our patients about factors affecting their choices and give clear advice, specific, and it should be individualized with respect to what goals we're going to set for our patients. And it ought to be a collaborative approach. I always like to use shared decision making with respect to pharmacotherapy. And we ought to assist the behavior throughout, so to help them achieve upon goals and acquiring the skills, the confidence, take into consideration food insecurity, for example, environmental issues that they need to overcome, get them linked to community resources. And follow-up and monitoring is always a very important feature of our services as pharmacists. So, in today's age, telehealth is the way to go, and I would definitely increase my patient contact through those services. So thank you very much, and I hope you enjoyed the presentation.
Thank you, Terry. This has been a wonderful presentation. Some housekeeping items. We are going to start the Q&A session, and you can either type your question in the chat box, or you can use the raise hand icon and your line will be unmuted. And while we wait for your questions, please, at the end of the webinar, remember to complete the survey. We have a survey at the end. Please do not forget, let us know your thoughts, let us know how we're doing. And that is very helpful for us here at the National Center for Health and Public Housing. And second, there are 5 handouts that you can either download right now from the GoToWebinar platform. And the slides, the recording, and the 5 handouts will be sent to those participating this afternoon. So in regards to coronavirus and all the activities that we are doing, we are working with public housing primary care grantees, and we are providing updated information on the needs and challenges and the services provided by public housing primary care grantees. You can go to our website, www.nchph.org, and get updates on the coronavirus pandemic and what public housing primary care grantees are reporting every week. You can also go to our website. You can look at the new publications that we have. We have Bridging the Digital Divide and how to develop cross-sector partnerships. etc. So you can go to our website and find the most recent publications, and you can join our mailing list and get her updates, funding opportunities, and resources and services, information on upcoming webinars, senior programs, and Medicare updates. So do we have any questions so far in the queue?
Yes, we do. So we have one question by Derek, and it says, is Bupro, I'm so sorry, but I'm gonna try to say the word properly. Is bupropion on its own worth a try in terms of weight loss? My wife actually tried Contrave and had issues with headaches and just feeling off. She wondered about trying bupropion on its own.
Well, I would definitely, it's not indicated for weight loss, bupropion by itself. It has been associated with weight loss. She can discuss it with a physician, and it can be something to look into. But once again, it's not indicated for that. And she might be a candidate for one of the other medications that are. If she does go with the pharmacotherapeutic approach, it's important that she also marries it with a weight loss management program. The drugs have not shown promise used alone. So that would be my advice to Derek. I hope that answers his question.
Thank you, Terry.
He said, oh, sorry, yeah, he said yes, thank you. It did answer his question.
Okay.
Great. Any additional questions?
Not right now.
Okay. Terry, this is a very important topic, and it highlights and underlines the need of the team-based care model. So everybody works together, the clinician, the nutritionist, the pharmacist, the nurses, to provide the healthcare services that patients need. It's when I see all the materials that you covered this afternoon, the potential side effects and indications, contraindications, is very important to gather all the medications that a patient is on.
Absolutely.
To make sure that we get the information, and the patient doesn't have a contraindication for any of the medications that you mentioned this afternoon.
Exactly. I mean, medications definitely do play a role in the treatment and management of obesity, but we have to remember that they have side effects and they have interactions, and many of our patients are on multiple medications, and it's important to assess and collect all of the medications at our meetings with our patients and at our encounters. When I met with my patients, I always had them bring in their medications so that we can reconcile them against the medical record and make sure that they were on track with their treatment, and also assess their comorbidities and work together with the interdisciplinary team. Many of these patients are not, it's not just obesity they're dealing with other comorbid conditions that unfortunately have to be treated and also pose risk with respect to adding any medication. So yes, it's important to take a look at the whole patient and not just the one issue.
That's correct, Terry. And the other issue that I would like to mention is the fact that in addition to all prescribed medications, we need to get history of any over-the-counter medication or natural remedies, you know, that can also interact with any of these medications.
Absolutely. That's one of the, especially if we are practicing in a community role, we are the best point of contact with respect to over-the-counter medications. And I'd like to mention also, in the Hispanic population that I had, a lot of them would bring in medications from their country. So it's very important that we have them bring in every single medication that they're on. And a lot of times I would find that there was duplication of therapy, that there was interactions with therapy, and with OTC products, the same thing can happen. You know, you have situations, for example, with cold medications. If you're on phentermine, now many of our cold remedies have stimulants in them, sympathomimetics that can interact with phentermine. So it's important that the pharmacist has the opportunity to stop that interaction from occurring before it happens.
That's correct. Terry, thank you so much for your feedback. Peter, any other questions in the queue?
Nope.
All right, so, well, thank you so much for attending this activity. On behalf of the National Center for Health and Public Housing staff, thank you for being part of this learning collaborative, and remember to visit our website. You can find publications and training materials and information on our conferences, and you can also contact us at any time. Please do not forget to complete the survey after this webinar. So thank you so much. Have a great afternoon. Thank you, Terry.